G'day, I'm Ted Jednach, creator and facilitator of the internationally acclaimed and accredited Foot Mobilisation Workshops, published author and founder and director of the Foot and Leg Centres in Australia. I help health practitioners master new treatment options so that you can have the best tools to help your patients get better clinical outcomes. It's all about making you a better practitioner by giving you effective choices that fix the problems you see in your clinic every single day. And I've got to tell you, I'm really excited about this blog because it's on a really hot topic, manipulation. This short video is going to give you the evidence-based lowdown on what manipulation actually is, how it works, and why its application should be in the armoury of every practitioner who treats musculoskeletal conditions of the lower limb. Fact versus fallacy, that's what's coming your way right now. First, let's start with the definition of manipulation and mobilisation. Man, is there some confusion in the literature? One lit review started badly with this declaration. Manipulation is one intervention for which a satisfactory definition is lacking. This particular review actually refers to Jeff Maitland's work too. And Jeff, as you probably know, was the pioneer of manipulative physiotherapy, right here in little old Adelaide, Australia. So as it happens, Jeff has a crystal clear definition of manipulation which is used all around the world. In fact, Jeff provides a grading system beginning with grade 1 mobilisation, which progresses to grade 4 mobilisation, and then grade 5 manipulation also comes at the end of the scale. Maitland defines manipulation as a rapid movement or thrust of small amplitude performed at a speed that renders the patient powerless to prevent it. This takes place beyond the joint's active limit. Now, some people hear the term beyond its active limit and go, whoa, that's not right, or that's dangerous, but that's just not the case. The active range of motion of any joint is always less than the passive range when a therapeutic force is applied. I'll repeat that because it's a very important point. The active range of motion of any joint is always less than the passive range when a therapeutic force is applied. Have a look at this image here. It graphically depicts a joint's active range limits, its passive limits and the sites of mobilisation and manipulation. You can see that even at the passive limits, the therapeutic force is still within the joint's capabilities. Now, yes, that passive limit is right next to the physiological limits of the joint, but crikey, when we're dealing with the ligaments and of capsules of joints of the lower limb, the structures are designed to withstand multiples of whole body weight. You know, even with my massive upper body build, I can only generate around 15, maybe 20% of the anatomical limits of the ankle or knee joint. Fact is, it's really hard to cause harm in joints of the foot or leg. As long as you've ruled out any of the contraindications of manipulative therapy and carefully evaluated your patient for this intervention, you're in pretty good shape. A key difference between mobilisation and manipulation is the speed of the force applied. With manipulation, the force is applied beyond a patient's voluntary control, meaning it's all over before they can oppose the force. Mobilisation, though, usually happens at a speed the patient could oppose. It's a bit like windscreen wiper speed, as long as you're out in a hailstorm. The other funky thing is the cracking or popping sound that can occur when a joint is manipulated. Some people love it, others can't stand the noise. It's like, fingernails down an iPad. Sorry, I'm just trying to keep up with technology, but if blackboards or chalkboards and that sound of fingernails scraping down, you get the idea, right? Now, listen to this. That noise is literally a release of nitrogen gas in my synovial joint. It's like a suction cap being pulled off a window. The rapid change in hydraulic pressure makes the noise. That's all. And no, it doesn't cause arthritis. In fact, it actually stimulates the production of synovial fluid. So if anything, it helps arthritis by putting the juice back in the joints. Now, if you keep wrenching the joints, yes, that can damage the joints. But the joint, in a therapeutic application, it doesn't cause any harm. So let's run through why you would need to manipulate a joint in the first place. Remember, manual therapies have been around for thousands of years. Chiropractic officially began in 1896. Physiotherapy kicked on with the world wars of the last century, and osteopathy hit its straps in the 1800s when it was founded by a medical physician and surgeon. Why did all of these professions find manual therapies essential? Well, we now have some reasonable understanding of the physiological benefits of manual therapies. The first is the physiological effect on collagen cross-fibre linkages. Now, these form in response to joint immobilisations or compensations. They end up interfering with the joint's optimum function, so releasing these knots or restrictions in periarticular structures would be a good thing, wouldn't it? Manipulation actually tears apart the knots and enables the tissues to heal and repair in a more functional, healthy state. This leads to increasing the mobility of hypomobile joints. That sounds like a good thing, doesn't it? In chronic joint stiffness, manipulative procedures play a major part in the regaining of the range of movement or function of the joint. Exercises help to maintain the range of movement gained from mobilisation. However, there are involuntary movements which cannot be performed by the patient at will. They occur as the joint moves, especially towards the end of range. Manipulation gives extra yield to joint movements. Such movements can only be done by a third party or a therapist, and these movements are termed as involuntary accessory movements, distinct from the gross or angular movements which are under a patient's control. It's thought that without proper treatment by manipulation, they may never return to normal. Self-mobilisation aids return of gross voluntary angular movements. For example, the lunge action is useful for improving ankle dorsiflexion. But those involuntary accessory end range movements beyond a patient's control need therapeutic manipulative intervention. It's these accessory movements which are affected to a greater extent by trauma and which full normal movement will be regained last. Mobilisation could achieve these results too, but generally it's a slower, more gradual process. Interesting, huh? You know, a really interesting field of study in more recent times has been the neurophysiological effects of manipulation. The researchers refer to the somatovisceral reflex. You see, somatic dysfunction is a key indicator for high-velocity, low-amplitude interventions. Muscles are hypertonic, they're boggy or stringy. It's a bit like a wooden window that gets stuck halfway. These joints need a multi-directional or oblique release versus just pushing harder in the correct direction. There's a little bit of play and checking and adjusting that needs to happen to get the window to slide just right. If you just tried to force it straight down, you might even cause more damage, couldn't you? Well, that's what happens with stuck joints. The art of the therapist is to find the right angle, the play, and then all of a sudden the joint just goes whoosh. That's the art of mixing the treatment with science. And let me tell you, sometimes you can get that effect with mobilisation therapies. It's just not as predictable in my experience. You remember learning about the gait control theory of pain in the spinal cord? It was first proposed in Melzack and Wall in '65, and it kind of went like this. Under certain conditions, a gate mechanism would suppress type 4 nociceptors from transmitting pain messages up to the brain. One of those conditions is manipulative interventions. Now, Melzack and Wall have since acknowledged some shortcomings in their theories in the 1970s, but further understanding has enabled us to know more about manipulation and how it works in relieving pain. I remember Howard Dannenberg writing about the immediate pain-relieving effects he'd witnessed after a single manipulation. Howard talked about the fact that nociceptors are antidromic, meaning they don't only send messages distal to proximal, they also send messages from proximal to distal. Now, in these conditions, the free nerve endings secrete an array of neuropeptides which are both pain-producing and vasoactive. Have you ever seen a CRPS case where a seemingly minor injury has caused a major pain and vasodilating action? That's the antidromic effect. Manipulation can sometimes reverse that effect with immediate spontaneous changes. It is truly amazing to witness. You can observe the immediate resolution of pain and abnormal colour. I happen to have haven't seen that happen with mobilisation treatments. The other mechanical phenomenon that manipulation can induce happens when, you have a patient that's telling you, I don't know, it doesn't really hurt, it just feels like it needs a good crack. Maybe you've experienced that sensation in your own body. I sure have. Just saw a patient yesterday who was the perfect example. Tam, a ballet student, 13 years of age, she just felt like her ankle needed a good crack. Now, because of the hydraulic nature of synovial joints, the synovial fluid, the tension that goes through and around the joints, sometimes mechanical compensations form when a joint shifts from its optimum position. And this can lead up to a build-up of hydraulic tension within the joint. The mechanoreceptors detect this tension and then tell the brain that the joint is full or stiff or stuck, and it's just not right. One manipulative force, that tension's released in an instant. Tam got up and went, oh yeah, that's better. You can only get those releases consistently with high velocity manipulations. Mobilisations won't generate the necessary therapeutic force required. I think being able to deliver the high velocity, low amplitude forces is one of the most useful skills any practitioner who's treating musculoskeletal conditions of the lower limb can provide. Heck, to summarise, the key benefits of manipulative therapies are 1. Manipulation quickly and effectively releases connective tissue restrictions of periarticular structures in hypomobile joints. This is really important in cases of joint compensations longer than 6 weeks. 2, the neurophysiological benefits and pain relief for treatment options for chronic regional pain syndrome or polymyalgia cases are just too great to ignore. And 3, the immediate relief you can provide with what we like to call our one-hit wonders, just like I did for Tam yesterday. It's a service that you can deliver that no other intervention can provide. So if you're not yet trained in manipulative therapies, get onto it. We've got our manipulation course coming up here in Adelaide next month, and I know there's only 4 places left, so they'll fill up in no time. Being skilled in manipulation will make you a better practitioner, and your patients will love you for it, no doubt. Hey, thanks for watching this video. I hope you found the information useful. Until next time, serve with spirit, consult with care, and help the health of humanity today.